In today's session, we're going to take a brief look at the physiology of pain. And when we're thinking about the physiology of pain, these are the key things that we're going to cover during this session. We're going to look at the categories of pain receptors and the pain fibers that are involved. We'll explain how that pain is processed at a higher level, so within the central nervous system itself. And we'll just touch on the cardiac pain pathway and the pathway from the GI tract. And we'll talk a little bit about referred pain at the same time. Now, why do we have pain? Well, obviously, the storage of painful experiences in our memory, because we have pain memories, it helps us avoid potentially harmful situations into the future. And it's accompanied by a variety of motivated responses, which are behavioral and also emotional. And so those motivated responses might include defense or withdrawal from whatever that harmful experience or painful experience is going to be or is being. And the emotional responses can include crying and that fear response that you also have. At the same time, you get subjective perception, and that perception of pain can be influenced by other past or present experiences. For example, a dentist visit. So if you've been to the dentist once and you've had a few fillings and it's a little bit painful and a bit unpleasant, you get that subjective perception of pain with that heightened pain perception and accompanying the fear of going to the dentist. But also you get that lowered pain perception in an injured athlete, for example, during a competitive event, because they just want to carry on with that event. So as we said, it's really a protective mechanism, and it's bringing us that conscious awareness that tissue damage is actually taking place or is about to occur. So it's very important in that kind of life-death situation. We need to get away from that damage, from that pain, and we need to protect ourselves. So if we're thinking about this, we've got these different pain types in this table, and I'd like you to think about it in each point. We have nociceptive, neuropathic, acute, chronic, what is pain threshold, and what is pain tolerance. So really what I'm asking you for is a description of each of those words or little brief sentences to the left-hand side. So press pause and have a little bit of a think about that and answer them in your own mind. Okay, so if we're thinking about nociceptive, of course, nociceptors are the pain receptors, and they're present generally on the nerve endings of our, but not always the nerve endings, but the nerve endings of our sensory receptors, sensory neurons rather. And our nociceptors are found in the skin, in the viscera, in our muscles, joints, meninges, in a variety of different places. And it's basically, they're important for that peripheral pain receptor stimulation, which transfers through those sensory neurons to the central nervous system, where it can then get processed. So you might have reflex responses, it might go up to your thalamus, where it gets relayed to different parts of the cerebral cortex for you to think about, so your frontal lobe, or go into your limbic system if you're thinking about emotional side of things, or to your somatosensory cortex if you're trying to localize that pain and have its intensity kind of told to you. How intense is it and whereabouts is this taking place? You've also got neuropathic pain, so that's where you've got abnormal nerve pathways or abnormal nerve function. And that neuropathic pain can be caused by damage to nerves in the central nervous system and the peripheral nervous system. And they include things such as trauma, surgery, diabetes mellitus, of course, and infections. Then we have acute. So this is where you have your nociceptive response to tissue damage, inflammation and disease with rapid onset. And chronic, where that pain lasts anywhere from 3 months upwards is what is generally said. But some depends on the resource you look at. But I tend to say 12 weeks or 3 months as a general rule. Then we have pain threshold, and this is very individual. And this is the point at which stimulus becomes painful. And of course, pain tolerance, the degree to which stimulation can actually be endured. And those are very personal attributes. So what about the nociceptors themselves? Where are they, and what are the receptors that we have? Well, we've got these three nerve endings that you can see here. So these detect pain and temperature changes. And so these are nice and simple. So this is where they are. We're looking at the skin in this case. So remember where other nociceptors are. They're in the viscera, the joints, the muscles, and the meninges. So these three nerve endings, they respond to tissue damage provided by providing pain sensations. And they can be stimulated by chemicals, mechanical pressure, so mechanical stimulation, temperature changes, and trauma, for example. We do have other receptors present within the skin, of course. We've got the Merkel discs, which respond to light touch. So you can see they're near the surface of the skin, near the epidermal layer. You've got the root hair plexuses. So these entwine around the hair follicles and are again responsive to light touch. You've got the mycinous corpuscles, which again respond to light touch, but this time in hairless skin. So again, they're up near the surface, near the epidermis itself. You've got Ruffini's corpuscles. They're responding to deep pressure and stretch, so they're a little bit deeper within the dermis. And you've got the Pacinian corpuscles, which again are relatively deep, so they're responding to deep pressure, vibrations, and in terms of visceral, they'll respond to pain, nausea, hunger, and fullness as well. So what I'd like you to do, just like in the last one, I want you to think about how you can answer this. What kind of stimulus will cause or stimulate a mechanical nociceptor? And likewise thermal, it's quite easy really, and polymodal. So we're thinking about what is the stimulus in each case. Okay, so when we're thinking about mechanical, we're thinking about mechanical damage, of course. So we're thinking about cutting, crushing, pinching, anything like that. If we're thinking about thermal, that's really obvious. That's going to be temperature extremes, in particular heat, but also cold, of course. And then your polymodal, they seem to respond equally to all damaging skin stimuli, whether that's mechanical stimuli, thermal stimuli, or chemical stimuli. So these nociceptors also include inflammatory chemicals that they respond to. So all these signals stimulate different subtypes of thermoreceptors and mechanoreceptors and chemoreceptors. And like I said, the polymodal nociceptors that we just talked about, these are activated by chemicals from damaged tissue, so your prostaglandins. But they're basically really just adapted chemoreceptors. So when you get that activation, so you get the activation of the receptor, then the information passes, you get a graded potential. So depending on the strength of the signal, if it reaches threshold, you get an action potential at the axon hillock. And that moves along the peripheral nervous system fibers to the central nervous system, where that information then can get further distributed throughout the CNS and then that information processed further. So a key question is, do nociceptors adapt to a sustained or repetitive stimuli? Well, as a general rule, they don't adapt because of their value in survival. So therefore, they remain active as long as the painful stimulus is present. And painful sensations therefore stop when tissue damage has actually ended. But there is some limited central adaptation which reduces the perception of pain through inhibitory centers in a variety of places, so the thalamus, the reticular formation, the lower brainstem, and within the spinal cord as well. So pain is actually transmitted by different nerve fiber types. And so when you're thinking about your mechanical and your thermal nociceptors, these, as we've talked about, are activated by mechanical changes or heat extremes. And in these cases, you get this sharp pain, and they're transferred by small myelinated A delta fibers. And they're quite fast, they're about 13 meters per second. And as you might expect from this, you can see that they're myelinated, and that's what's making them faster, obviously. You've then got these polymodal nociceptors, and these are activated by chemicals and other stimuli, of course, from damaged tissue. And that's where you're getting these polymodals, where you're getting this dull, chronic pain. And these are unmyelinated C fibers, and they're much slower at about 12 per second. At both points, if we're looking at the receptor coming in from the hand in this case through our sensory afferent neuron, when it synapses in the dorsal horn, they release either glutamate or substance P, and these then go on to activate second order neurons and ascend to the brain. Or, of course, if you're touching something hot, they'll also trigger those reflex responses up and down the spinal cord. So what is really activating these receptors? Well, obviously, when we're thinking about the chronic slow C fiber pain receptors, they're activated by a variety of receptors released from injured tissue that combine to those polymodal nociceptors. We're thinking about things like bradykinin and acids and ATP and potassium. But interestingly, they also serve to lower the activation threshold, so you become more sensitive to pain in that area. A great example that you can think about is damaged tissue due to sunburn. You just have to touch that very gently. That wouldn't normally stimulate any pain, and all of a sudden you're getting intense pain through just gently touching that sunburnt region. So when we're thinking about this overall pain, and we're thinking about the fast pain, and we're thinking about the slow pain, when you cut or you burn your finger, you feel a sharp pain at first, which is easily localized, so that's your mechanical or your heat, and then coming in with that more diffuse and disagreeable dull pain, commencing shortly afterwards and lasting for longer. So that's your polymodal response in response to some of those chemicals. And these chemicals persist longer, or rather they persist for an extended period, hence why that pain can last for a decent amount of time, even when the heat nociceptor, in inverted commas, is no longer activated. Just as a side, the active ingredient in chili, which is capsaicin, I never know how to say it, that binds to both thermal receptors, hence the feeling hot, as well as the slower C afferent fibers. And ironically, application of capsaicin can actually reduce clinical pain by overstimulating and damaging the nociceptors which it binds to. Just a little interesting side topic for you there. So, the presence of prostaglandins from these damaged tissue greatly enhances the receptor response to those noxious stimuli. So the tissue injury itself leads to this release, or this local release rather, of prostaglandins from that damaged tissue. And as we already know, or you presumably already know, prostaglandins are fatty acid derivatives, and they act locally once they're cleaved from the lipid bilayer of those damaged cells. And that's that localized tissue injury that we're talking about. So they act on receptor nerve endings and therefore lower that nociceptor threshold for activation. And as I said, we've given you that good example already if we're thinking about sunburn. And so this is your pathway of prostanoid or prostaglandin synthesis, and you can start it. It starts with the arachidonic acid within the cell membrane. That gets cleaved by the COX enzymes, and you start to form the prostaglandins. And of course, aspirin inhibits the synthesis of the prostaglandins, which helps to contribute towards its analgesic effect, therefore reducing that pain perception, even in the presence of the same stimuli. So what I'd like you to do now is, this is a little summary place we're up to. I'd like you to complete the following table. So take a look at the characteristics of the nociceptor type. What's the fiber type? So we're thinking about A delta and C fibers. What's the sensation type? Is it easy to localize? And which occurs first and second? That one's kind of really bit easy. So just press pause, have a little bit of a look through the table, and we shall go through it. Okay, so fast pain. What's the nociceptor type? Nociceptor type. What's it respond to? Well, it's mainly mechanical and thermal stimuli when we're thinking about that fast pain. And then you've got your slow pain. Obviously, this is polymodal, and it's responding to everything. So it responds to mechanical, it responds to thermal, but also those chemicals. Remember the chemicals like the bradykinins, etc., that are released from damaged tissue. What about the fiber type? Well, the fiber type for fast pain is those small myelinated A delta fibers. So they're myelinated, making them nice and fast. And of course, you've got the slow pain carried on the unmyelinated C fibers, so not as fast. Sensation for your fast is sharp and prickly, whereas the slow pain is dull, aching, and burning. Easy to localize. Fast pain generally much easier. So the slow pain not so easy to detect or localize rather. And of course, the fast pain occurs first, and the slow pain occurs afterward. And it, like I said, it persists for longer. It's more unpleasant, and it gives you that more diffuse pattern that is not particularly easy to localize. So that's the first part that we've covered today. So we've looked at the categories of pain receptors and the pain fibers. So now we're going to take a little bit of a look at the higher level processing of pain input. We're only going to look at it at a reasonably basic level as well, hopefully anyway. So when we're thinking about that higher brain inputs, thinking about this, we go down noxious stimuli, whatever it might be pressure, it might be chemicals, it might be temperature, but we're stimulating these nociceptors. You then get a graded potential, and if this graded potential is large enough to breach threshold at the axon hillock, we get an action potential, which moves along our afferent pain fiber. Okay, so this is also called our first order neuron. So this moves to the end, and we get release of a neurotransmitter, of course, and that neurotransmitter in this case is substance P, or glutamate. And these synapses within the dorsal horn onto an excitatory interneuron, and of course then that travels up through the CNS to to the thalamus, the reticular formation, etc. And we'll talk about that in a few minutes. So really this second order neuron, which is this second one, synapses with the first order neuron, like I said, in the dorsal horn of the spinal cord, in the example that we're giving. It's also quite important to remember that there are other interneurons and efferent neurons, and they help to relay information from that anterior horn to potentially cause reflex muscle contractions away from the source of pain. For example, if you put your hand onto something really, really hot, you know that your reflexes are to move your wrist away, or if it's really bad pain, to move your entire arm, and if it's exceedingly hard, nasty pain, you actually jump away. So those reflexes are going up and down the spinal cord, trying to get you to move away from that pain. So, like I said, the second order neurons relay information to different regions of the brain and the brain stem, and we'll talk about that. And the interneurons also stimulate those reflexes. So we've already covered that a little bit, so I'll move on. So here's that same diagram that we just looked at. So we've got our nociceptor, the noxious stimuli, release of substance P, and glutamate. Now, some of that, but as we go up to the spinal cord, we come to the thalamus, where we get this pain perception. So the thalamus is a wonderful little area. It gives us this information to tell us there's some pain going on, but I don't really know how bad it is, and I don't really know where it's localized, but it's kind of telling you there's pain happening. And it's this relay station. So it goes, oh, I've got to send this information to the right place. And it sends it off to our somatosensory cortex. Remembering that's our cerebral cortex, which is the grey matter, which is the computer, if you're thinking about white matter and grey matter. And that gives you that pain intensity and the pain localization. We also get the information going through the reticular formation, which is present in the brainstem, and that gives you your increased alertness. And so the reticular formation, really put simply, activation of this through whatever the signal might be. So it can be pain, it can be temperature changes, it can be loud volumes, it can be all manner of things. But you get activation of the reticular formation in the brainstem, and it's involved in alertness and wakefulness. And so simply put, activation leads to arousal, and dampening leads to sleep. And you've sometimes, I'm sure you've all driven at some point and you're feeling a bit sleepy on the motorway, it's late at night, and you have to go, I'm not going to pull over, I'm going to get to my final destination. And so you wind the window down, and all of a sudden you've got this cold air coming in, or air at least coming in. You put the aircon on really cold, you turn the music up really loud, you pin your eyes open. I've done that before. No, I haven't, because I wouldn't ever drive when I'm tired. Obviously, I would pull over, being a sensible chap. And you put that, what did I say? You put the aircon on, you might slap yourself across your face. All of those things are stimulating a variety of receptors, whether they're pain receptors, temperature receptors, pressure receptors, whatever it might be, audio receptors, if I want to call it that, terrible phrasing, special sense receptors. And they're all coming in and activating the reticular formation, and the reticular formation has contacts throughout the cerebral cortex, so it starts to activate the whole cerebral cortex to make you, or attempt to make you, feel more alert, and therefore not fall asleep. But as when driving a car, which isn't very sensible. Anyway, so it's also giving you that increased alertness. And then you're also getting this conversation going on with the hypothalamus and the limbic system. And the limbic system is to do with your emotions, and it's starting to think about the behavioral and emotional responses that you might have to pain, whether that's crying or having immense fear or doing a run or whatever it might be. And of course, there are other areas of the brain, such as the frontal cortex. They have other conscious components. And so you might start to deliberate about the incident. You might go, that was an interesting bit of pain. Maybe I was a bit silly doing that. So you start and, maybe I'll move away from that. It's not very sensible. So you have all these different areas of the brain working together to fully process the brain itself. Did I say fully process the brain? I meant fully process the pain. Okay, so how does the information actually get up to the brain from the spinal cord? Well, this is your spinal cord. Obviously, you've got our white matter. This is where the information is being transferred around. And we have our grey matter, which you can see, and that's like the computer. And of course, you've got the dorsal horn, which we've taught, or the dorsal roots, sorry, coming into the dorsal horn. And that's where the information, the sensory information, is coming in. And it's synapses in different areas. And you can see these shown in this image. This is where your somatic information, so you're thinking about skeletal muscle, and your viscera, thinking about your organs. Okay, and then you have the ventral root with the motor responses going out again. And so when we're thinking, so that's the grey matter, but when we're thinking about the white matter, it's divided into 3 columns or funiculi. And so we've got the posterior white columns, or the dorsal white columns, and these are in between the posterior grey horns and the posterior median sulcus. So there's your grey horn, posterior grey horn, and here's your posterior median sulcus. So there it is. You've also got your anterior or your ventral white columns, and as you might expect, they're in between your anterior median fissure, of course, and your anterior grey horn. Again, nice and obvious where that's located. And you've also got your lateral white columns, which are between the anterior and the posterior columns, as you can see. So these columns are basically bundles of axons, and they have a relatively uniform diameter, myelination, and conduction speed. They also actually relay the same type of information, whether that be sensory or motor, and in the same direction. And of course, these columns have axons going up and down the spinal cord and to and from the brain. But like I said, these columns, it's all written up there. They have bundles of axons. They share characteristics, and as we've already just touched on. So here are a few examples of those columns. So we've got some descending tracts, which are shown in red. So these are ones that are obviously going downwards. And we have the ascending tracts, the ones that are going upwards towards the brain. And so there are lots of them, and they carry different types of information that we've already talked about. And so these are multi-neuron pathways that connect the brain to the body periphery. So we have the first order neuron coming, which is our sensory neuron, going to our second order neuron, which is the one going up the spinal cord, and then the third order neuron, which synapses with the second order neuron in the thalamus and goes to wherever it needs to, the somatosensory cortex, for example, when we're thinking about the ascending tracts. So, like I said, each tract is made up of axons with similar destinations and functions. So the dorsal white column there, you can see that's involved with fine touch, and it goes via the thalamus and onto the somatosensory cortex. You've got the dorsal and ventral spinocerebellar tract. It's quite obvious what they're going to be involved in, because it's spino, from the spine, to the cerebellum, which is involved in coordinated movements. And so it's coming from your limbs. So we're thinking about proprioceptive information. Where are my joints in space? We've got the ventral spinothalamic tract, again going from the spine up to the thalamus, so that's to do with touch, and this time it's crude touch. And then we've got the lateral spinothalamic tract, which again is going from the spine to the thalamus and is involved in pain and temperature. And you get those pain signals going from the skin and our viscera up the spine, up the lateral spinothalamic tract. So the ascending pathways relay impulses to the appropriate cortical region. So we're just going into a little bit of more detail again, because I've just explained how the signal is transferred to the brain through a chain of neurons. So we've got that first order neuron, the second order neuron, and the third order neuron. So if we're looking at this, we've got fine touch, proprioception, vibration. We've got nociception, so pain, temperature, and our coarse touch. We've got all those different signals coming up through different tracks that we've already talked about. But the first order neurons, they conduct impulses from the receptor level. So we're thinking about nociceptors, of course, to the spinal reflexes, or to the second order neurons. So here is our first order neuron. So you can see nociception coming in at the level of the spinal cord. You can then see our second order neuron, which is in red. So second sensory neuron, they've called it. I thought first, second order neuron. That is then transmitting, that crosses over, as you will know, and transmits the information up to the thalamus or to the cerebellum. Okay, so it will go to the cerebellum when we're thinking about proprioceptive information. And then your third order neurons will go from the thalamus to the somatosensory cortex, for example, to get that localization and intensity signal. So when we're thinking about it, some neurons from the non-pain system, so we're thinking about those proprioceptive ones, so proprioception in the joints, their second order neurons just stop in the cerebellum to help with that balance and posture. So if we're thinking about proprioceptive information, some of them do stop and don't have a third order neuron going on from the cerebellum, for example. But you do have conscious awareness of where your joints are, so that will go up via the thalamus and onto the that information does also have conscious awareness associated with it. So what about pain? Well, pain can actually be blocked by the brain's inbuilt analgesic system. And that's because there are specific brainstem nuclei, which are just collections of cell bodies, that suppress transmission in the pain pathways as they enter into the spinal cord. They then go on to stimulate those inhibitory interneurons to release a variety of endogenous endorphins and enkephalins, so opiates in summary, that help to reduce that pain. Though the signal is still going to be there, you just don't feel the pain coming from it. So here's this little summary image that we had before. Here's our noxious stimuli stimulating our nociceptors. We're getting our action potentials. We're coming to the end. And without this perception or the blocking of pain, we release substance P and glutamate, and we stimulate the second order neurons. And we go up to the thalamus and then up to the somatosensory cortex, where we're going, ow, that hurts in my little finger, wherever it might be. But suppose we want to get rid of that pain, or we don't want to feel it. Well, there are lots of things that will influence this. So when the nociceptive information is actually received by the brain, an assessment of other important information is also undertaken. So do you need to escape from a really dangerous situation, whatever that might be? Is it a life-death situation? What about the memories you have with regarding to similar pain situations? How much pain actually is there? What about the emotions involved? What's your emotional state? Do you remember something like this happening before? Is this going to alter how things go on? But also it has to talk to the hypothalamus and think about homeostatic situation. What is the situation within the body as a whole? So all of this information is assessed. And like I said, with that pain information, the brain makes a decision on how to proceed. Does it let you feel the pain to a large degree? Or does it kind of go, no, I think it's time to suspend recognition of this injury. It's a bit of a life-death situation. And so then lots of information comes in and talks to lots of different nuclei within the CNS. And one of those is the periaqueductal grey matter. And you get activation of this periaqueductal grey matter. And then through a variety of other nuclei, such as the raphe nucleus, you get the release of endogenous opiates, such as the enkephalins and the endorphins. And then through these regions, we're getting those inhibitory impulses to the C and A delta fibers. And therefore, when they release that opiate, they're inhibiting the release of substance P and therefore reducing the pain signaling going from the sensory receptor onto the second order neuron and beyond. So therefore, you're inhibiting those ascending pathways. But it does also reduce pain sensation at the level of the brain as well as at the spinal cord as well. There are other stimuli that can stimulate this endogenous opiate pathway. You'll all have heard of runner's high through exercise. Stress has an important role. Acupuncture is thought to play a role through this, the synthesis and release, or rather I'll just say the release of endogenous opiates, reducing pain. And of course, if you bang your head really, really hard, for example, you rub that and you go, ow, 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 and you rub it and the pain goes away quite quickly. And that's thought to be through a similar mechanism. It's called the gate control theory, but the mechanism is thought to be very similar to this. Oh, we have an MCQ for you. So have a little bit of a read and then I shall go through it with you. Okay, which of the following are correct? Primary afferent pain fibers release substance P with second order efferent neurons in the spinal cord. No, that's incorrect. They're second order interneurons in the spinal cord, not efferents. Pain ascending pathways synapse on the somatosensory cortex, which determines pain localization. Yes, that is correct. That's what the somatosensory cortex is doing. It's telling you whereabouts is this pain localized, and then depending on the frequency of action potentials coming into it, it'll tell you what's the intensity of that signal as well. Stimulation of the reticular formation by second order neurons increases alertness. Yes, that is correct. The second order neurons pass through and synapse onto the reticular formation and therefore activate it. And when you activate the reticular formation, you activate the whole of the cerebral cortex to give you that alertness. The descending lateral spinothalamic tract carries pain signals to the higher brain centers for interpretation. Well, if you get this one wrong, it's all a bit tricky for you, isn't it? Because it's clearly going to be an ascending lateral spinothalamic tract, not a descending lateral spinothalamic tract. Nasty question, bit silly really. Okay, next bit. So next bit I've lumped in together. We're really just going to talk a little bit about the visceral pain pathways and touching on a bit of referred pain as well. So, as a general rule, visceral pain is diffuse and fairly poorly localized. And in fact, visceral nociceptors are few and far between. And therefore, they have to have a large receptive field. And this also means that it's difficult or often difficult to determine the exact source of a painful sensation. When you do get that pain, it tends to be deep and it tends to be a dull pain. It can be triggered by a variety of different things. So you've got smooth muscle distension, contractions, ischemia, necrosis, irritation by chemicals during inflammation. There are all manner of things that can stimulate it. And there are emotional responses and autonomic changes that also take place. So those emotional responses and autonomic changes include things like nausea and vomiting, but you also get those autonomic changes like your heart rate or blood pressure changes as well. So when we're thinking about visceral pain, we need to think about what are the variety of receptors. Now, they usually use the A delta and the C fibers, remembering which one's fast, which one's slow. Quickly tell me, or tell yourself, because I'm not going to listen. A delta fast, C slow. Yes, I'm sure you got that right. So what have we got in the heart? Well, we've got both. We've got the A delta and the C, and they respond to a variety of things. They respond to your prostaglandins, your hydrogen ions, ischemia, potassium ions. So they're responding to a lot of different things. What about in our lungs? Well, we've got A delta fibers. They're responding to our irritants, gases, mechanical changes in the lungs, so mechanical stresses. And with the C fibers, which are also called J receptors, they respond to things like capsaicin, edema, and irritants, as well as things like pulmonary congestion. Then we've got the GI tract. We've got mechanoreceptors and chemoreceptors, both A and C fibers, and they respond to things like mucosa irritation, distension, bloating, cramping, as well as powerful contractions and impact, appendicitis. There are lots and lots of things that they can respond to. But the GI is interesting, and it does have rapidly adapting and slowly adapting mechanoreceptors, as well as those A delta and C fibers. And then we've got the urogenital tract, where we've got the C polymodal nociceptors, which respond to noxious heat and chemicals and mechanical stimuli, for example. And so what this is telling us is that we've got the nociceptors in the viscera. They're basically free nerve endings of the A delta and the C fibers. They're located in lots of these viscera, so the heart, the respiratory structures, the GI tract, the urogenital tract. These receptors can respond to stimuli that have the potential to damage tissue, or to stimuli resulting from the presence of damaged tissue itself, of course. For example, like we've said, that was intense stimuli such as overdistension. We've got ischemia, the endogenous compounds, so those chemicals like the bradykinins and prostaglandins and hydrogens and potassiums. They can all activate these visceral nociceptors and produce pain. Okay, so we have input from our visceral nociceptors. It's conducted almost exclusively by sympathetic fibers. Now, the sympathetic nervous system and the parasympathetic nervous system, divisions of the autonomic nervous system or the visceral system, have often considered, or in the past were considered, to mainly be motor, so in other words, efferent, which then go to travel through sympathetic, such as your splanchnic and cardiac nerves, or parasympathetic, such as your vagus and pelvic. But actually, they do have that viscerosensory or the visceral afferent fibers, and they have some very important roles. It's interesting also that the visceral sensory afferents tend to predominate mainly in the parasympathetic nerves, but are comparatively sparse in the sympathetic. For example, more than 80% of the fibers in the vagus nerve are viscerosensory, and of course that's parasympathetic, whereas less than 20% of the fibers in the greater splanchnic nerve are visceral afferents, and that's obviously a sympathetic nerve. And as you might expect, and as we've already said, most visceral afferents, so those are the sensory ones, remember, are either unmyelinated or very thinly myelinated, and therefore relatively slowly conducting fibers. But even though both the parasympathetic and the sympathetic are carrying this sensory information, the nociceptive information is almost exclusively carried by the sympathetic nerves. So therefore, there's a division of responsibility, if you want to call it that, between the parasympathetic and the sympathetic nerves in terms of their viscerosensory input. So information, for example, resulting from physiological receptors, so that's your inoculous inputs, is conveyed primarily by fibers contained in the parasympathetic. In contrast, input from nociceptors, so that's they are not innocuous because it's nasty, is conducted almost exclusively from the sympathetic nerve. So you can see how they kind of have different roles. Parasympathetic carrying the normal functions, so have we got a bit of stretch going on that's normal, etc. Whereas the sympathetic is going, are we carrying some pain? So the figure that you can actually see in this case, you can see we've got our nice thoracic region and our viscera here, and we've got abdominal viscera showing over here as well. And so when we're looking at this, the primary sensory sympathetic afferent fibers are shown in red. Okay, so these are sympathetic, so we're going to be thinking about pain in this case. And so they're shown in red coming from the heart in this case as an example, and from the abdominal viscera in this case as an example. And they're showing where they're coming in, so the abdominal coming in at T5 ganglions, the sympathetic ganglion, and you can see the thoracic coming in at T4 and T5 as well. And so then when we're looking, we're following it through, so it's coming in through, it passes through the white rami, into the spinal nerve, through the posterior root ganglion, and into the dorsal horn, or the posterior horn, where it synapses. And it synapses with the, or therefore conveying visceral information to the thalamus and to the general viscerant efferent neurons, which are in blue. So they're the general visceral efferent neurons. So that's blue, not so important for what we're talking about. So as you can see in this image, the afferent fibers conveying nociceptive information from the thoracic, which is here, and the abdominal viscera travel by the cardiac nerves and the splanchnic nerves. And so, for example, you've got your primary sensory fibers that originate from the stomach. They pass through the greater splanchnic nerve, as we're showing here, enter the sympathetic trunk, make their way up the sympathetic trunk, and pass through a white ramus or a white rami to join the spinal nerve, and therefore, and through the posterior root ganglion and the dorsal root horn, and then on, as we've already talked about. And the nociceptive input from the pelvic viscera, for example, such as the prostate and sigmoid colon, that's conveyed by these sensory fibers traveling through the hypogastric plexus and the lumbar splanchnic nerves. So you can see how they're coming in through these different regions. And the cell bodies of origin of sympathetic afferent fibers are located, as you'll probably know, or hopefully know, in the posterior root ganglia at about levels T1 to L2. So that's just to give you the locations as a general rule. So now we'll just touch on referred pain. Now, referred pain occurs due to the convergence of different afferents onto the same dorsal horn neurons in the spinal cord. And in this example, again, we're looking at the heart, and we're looking at sensory nerve fiber coming in through the sympathetic ganglion, through the white rami, through the dorsal root ganglion, and into the dorsal horn. And at the same time, what you're seeing now from the skin, you're seeing nociceptors being stimulated, coming in at the same level of the spinal cord and through the same pathway, and they'll be going up the same lateral spinothalamic tract. So therefore, you've got afferent signals from the viscera and elsewhere, such as your skin dermatomes, actually converge. And the signals relay along the same spinal cord tracts, like I've just said, to the thalamus, and then onto the somatosensory cortex. And in the somatosensory cortex, the pain is misinterpreted as coming from the arm or elsewhere instead of from the heart. And that's really because it gets a little bit confused, because it's used to lots of signals coming in from the arm or the back or wherever it might be, or the jaw to the somatosensory cortex, but not from the heart. And as those signals are coming along the same tracks, and as they're entering the spinal cord at the same level, and as they're going to the same regions of the somatosensory cortex, they're interpreted as coming from the location that is most likely. So the arm or the neck, for example. So referred pain is therefore occurring due to convergence of different afferents onto the same dorsal horn neurons in the spinal cord. And what about the damage that's actually occurring? So if we're getting damage to our viscera, so that includes heart tissue and GI tissue, causes release of chemicals that we talked about, so adenosines and hydrogens and potassiums and bradykinins. We therefore get some nociceptor activation. We therefore get some neurotransmitters. We get action potentials in our sensory neuron. We get the release of neurotransmitters such as glutamate and substance P, and we get second order neuron activation. We then go into the ascending pathways, where we go to the thalamus, where we're getting that pain perception. Yeah, there's some pain happening. the somatosensory cortex, which tells us, oh, it's really bad pain and it's localized in this location. And we're getting those limbic responses. We're getting those emotional responses. Oh, it hurts. So we're getting those impulses. But of course, we're getting this convergence. That's the whole point of this referred pain. So the usual input coming in at this point, or what we're used to getting, is from the skin. So we're getting this second order neuron activation. It's going the ascending pathways. And then we get this pain that is being localized to the skin or to the shoulder. So, or to wherever it might be, depending on where that is. So, for examples, if we're getting sensory afferent inputs coming from both the shoulder and the central diaphragm, they converge on the pain transmission neurons in the third and the fourth spinal segments. So we now know that if we're getting some diaphragm pain, we're thinking, oh, we may get referred pain up near the shoulder because of this. So in other words, this convergence, plus the fact that most pain-related inputs actually come from the skin and not from the diaphragm, means that inputs actually coming from deep structures are mislocated by patients to the relevant region of the skin. In this case, the shoulder. So therefore, inflammation near the central diaphragm is often reported by patients as actually pain or shoulder discomfort. And of course, the similar principles are happening for the GI and heart-related pain. The referred pain mechanisms are the same. So finally, we'll just think about where some of the regions of the body surface where perceived referred pain can actually felt. And there are lots of examples. So as discussed previously, referred pain can be felt in many locations because of those convergences of sensory neurons. So if someone has a heart issue, so they have an MI or angina, that will often be felt. As you can see from this, it may be felt within the so it can be felt in the neck, in the shoulders, and the back, rather than in the thorax, but also sometimes in the jaw or the left arm, as we're seeing in this image as well. We talked about the lungs and the diaphragm. Where's that up here? So lungs and the diaphragm, there you go. So that can be felt in the shoulder and neck. You can think about the liver and the gallbladder. And again, it's usually felt in the upper right area of the abdomen, just below the ribs. But sometimes people will also feel it in the right shoulder as well. So that's being shown up there. The stomach, you can see, is often felt in the upper back region. And the examples go on. So you can take a look at this diagram to give you some of those classic examples. But an interesting one, of course, is brain freeze. Now, I get brain freeze really badly. I probably shouldn't even touch another ice cream in my life. Whereas my son can eat as many ice creams as he likes and never get that brain freeze. Most unfair. But that's another example of referred pain. And it's thought to be because the vagus nerve in the throat or the trigeminal nerve in the palate transmit pain signals due to the rapid cooling and rewarming of the capillaries in the sinuses. And that's thought to be the mechanism of that referred pain in that case. And there endeth the session.